Okay, we are shortly going to start the recording of this event. I just clicked the button, so we start recording at the moment. So welcome to the webinar, and hello, my name is Dr. Suja Somanadhan. I currently working as an assistant professor and head of subject children's nursing at UCD School of Nursing, Midwifery and Health System. I'm also currently leading the RAINDROP, which is involuntary interdisciplinary participation, a partnership which we formed in 2018 with people and the families living with rare diseases in Ireland. This is a public patient involvement PPI partnership, voluntarily established in 2018 as a collaborative research partnership. In this partnership, we have people, scientists, researchers, health and social care professionals, and most importantly, parents and patients and the community of rare diseases. And today, RAINDROP, in collaboration with the RATAC, the raising awareness of rare diseases throughout all community at the Queen's University Belfast, we are hosting this webinar in collaboration to raise the awareness of the executive dysfunction in the classroom, the impact on children with rare diseases. As we know, 75% of rare diseases affect children and 80% of them are genetic origin. It's very important. There are 300,000 people living. Altogether, we have 400,000 across island of Ireland. I think it's important that the population is affected very badly, and then the children is most importantly affected. I think this discussion is going to set the scene, how important to understand executive functioning at all different age group, with the focus on children with rare diseases, and with the particular focus on sickle cell and phenylketonuria. So I'm joined by my colleague Anne Lawlor, and she's also part of the RAINDROP. So I'm going to ask Anne to do a quick welcome as well. Before I do hand over to Anne, make sure your microphone is turned on during the presentation, and the moderation will be carried out by Professor Amy Jane McKnight from Queen's University Belfast. We have all the speakers here. So Anne, I'm going to hand over to yourself. Will that be okay? Thank you.
Hello, Suja, and hello, everyone. My name, as Suja said, is Anne Lawlor, and I'm the mother of a now adult with 22q deletion syndrome, and I'm also the chairperson of 22q11 Ireland. So 22q is a common rare condition, and I'm delighted to be here today to have a look at this topic, because it goes beyond, it's the care that goes beyond medical needs that so many children with rare conditions need to have looked at. School is such an important place for children, any child, and for a child with a genetic condition who has both complex physical needs and perhaps complex cognitive issues going on. This is a really important topic. So I'm very pleased to be here, and thank you, Suja, for organizing it.
Thank you, Anne. So further ado, we are going to start the critical conversation, very much like a spotlight talk. So our first speaker, Dr. Michelle Down. Michelle is an assistant professor and Astra fellow in the School of Psychology at UCD University College Dublin, Ireland. So I'm going to share Michelle's profile through the chat. So you can read through and then you can follow Michelle through Twitter as well. So Michelle, I'm going to hand over to you for your talk. Thank you.
Thank you, Suja. Okay, so I hope you can all see my screen. So I'm going to introduce executive functioning first, and just to give a brief overview of what it is, because it is something that's highly debated, and because it is an umbrella term for a number of things, I think that's partly why it's misunderstood and not often discussed in terms of everyday contexts and in the classroom. In more recent years, it's definitely garnered a lot more attention. When I began my PhD research, there were no tests, for example, for young children in order to tap into their executive skills. If you had a child below 6, the only existing measure was really standardized, was to ask a child to stand still and see if they moved, if you dropped a pencil and so on. So I think, given that the research has come so far in the last 10 years or so, I think it's timely now that we're seeing a translation from the lab into the classroom, and a better understanding in everyday contexts for children with rare diseases and other disorders that impact executive functioning. So I'm going to give a little overview of what executive functioning is, and then talk about it in the context of sickle cell disease, which is a rare condition which is becoming more and more prevalent in Ireland in recent years. The end of the presentation is going to look a little bit at some of the research we've done with Irish teachers in terms of their understanding of executive functioning and how they see their role in terms of helping and supporting children in the classroom, and the barriers that currently exist. So for those of you who are unfamiliar with the term executive functioning, it's essentially an umbrella term for a number of background learning skills. So cognitive skills such as inhibitory control, working memory, cognitive flexibility, problem solving, attention control. So all these everyday skills that are required to actually sit down and pay attention in order to achieve in areas such as literacy and numeracy. And it's a really complicated picture. I mean, it's often described as executive functioning, the orchestra conductor of the brain, because the areas of the brain that kind of subserve executive areas are mostly these kind of frontoparietal areas of the brain. And these areas of the brain are the slowest to develop. So they show the most protracted periods of development. So the brain doesn't fully develop, the different areas of the brain don't fully develop at the same rate across the board. You have different areas developing at different rates. And these frontal areas that are really important for executive skills like inhibitory control or cognitive flexibility take a very long time to develop. And research shows it takes up to 20 years for these brain systems to mature. So that means that children with genetic conditions or other types of disorders where the development of this brain system may be impacted for a number of reasons, are vulnerable to executive issues because of this protracted period of development. But also there's scope and there's room for intervention there, and the right intervention, early supports can have a huge impact and huge returns. So in terms of how executive functioning actually impacts a child in the classroom, it really enhances a child's school readiness from the outset. So a child entering the classroom context who has strong executive skills will find it easier to listen to teacher when teacher gives them a number of directions in one go. So for example, take the book out of the bag, turn to page 5 and do question 2. So when a child is asked to do something like that, there's a number of things happening at the one time. They have to pay attention to what the teacher's saying. They have to stop themselves from being distracted by distractors in their environment. And they have to sequence. So they have to go from one step of that sequence of events to the next. And they have to kind of organize themselves and plan themselves and self-monitor. And they also have to be able to flexibly shift from one thing to another. So, teacher says, okay, now we're going on to this, and now we're going to do that, or we're going to change the topic here. So all of these skills are really, really important. And historically, they've been very difficult to measure in children because these systems take a long time to develop and mature. So if you're, for example, looking at a 6-year-old, their attention skills, their organization skills, their decision-making skills are still developing. And so they inherently have poor attention and poor planning skills. So it can be really tough to actually develop measures to tap into some of these skills. And I think that's why there's been such a delay in terms of actually translating research into the classroom context. And I think it's worth mentioning as well that these executive skills are not just important in terms of academic achievement, but they're important from everyday perspectives in terms of other areas of life that are important to the child and the family. And one example is social interaction. So if you're a child and you're playing a game on the yard that has rules and you're interacting with a number of different children, you have to pull on your different executive skills. So you have to use your working memory to remember whose turn it is and where the ball is is going. You need to use your inhibitory control to stop yourself from maybe grabbing it and running away or hitting out at another child. And you need to be cognitively flexible. So when the rules change, you can change and keep up with the game and keep up with your peers. So in terms of executive functioning and the rare disease context, so I think when we think about executive functioning and that umbrella term of specific subdomains underneath the broader term of executive functioning, the profile across different children who belong to different patient groups and populations differs depending on their diagnosis and a whole host of other factors, because we know that environmental input is really important as well for executive functioning. So things like home environment, sleep, family factors, as well as the child's medical history can have an impact on the brain systems that are developing beneath this behavioural skill. But in the context of sickle cell disease, so I first worked with this group of children in the UK. And often when people think about sickle cell disease, they think, okay, so a child with sickle cell disease, they're more likely to experience a clinical stroke. So that child is more likely to need neuropsychological input and educational support in school. But actually, over the last decade or so, there's been loads of research to show that even children without stroke show executive difficulties which increase over time. So some of these children, if they undergo scanning, we can see that even though they mightn't have had a clinical stroke, which shows a sudden change in behaviour, they might show damage in terms of their white matter structure, and that integrity might be impacted, which could have subtle impact on their cognitive functioning. And even without any kind of white matter hypotensities or anything visible on the brain, these children show more and more executive issues as they develop over time. So in terms of what's happening behind the scenes for this particular group of children, these children, their red blood cells, you can see here in the image on the left of the screen, instead of having these kind of biconcave shape, the red blood cells are sickled in shape, and they essentially don't carry oxygen around the body as efficiently as anybody else. And they also break down a lot faster, which leads to clunking of the vasculature in the brain. So you can see down in the bottom hand corner here an example of a transcranial Doppler reading. So this is just showing that these children, because the blood isn't carrying oxygen as efficiently, the blood is actually speeding up when it's traveling around the brain. And high cerebral blood flow velocity is indicative of a child who's more likely to experience stroke. So in terms of, the actual impact on day-to-day life and executive functioning, up until recently, we knew that older children, so adolescents and adults had issues with executive functioning. But more recently, we've done research to show that even at a preschool stage of development, these children are showing difficulties with executive functioning. And this is really important to demonstrate, because it's not just that these children are missing out on more school, which they are, but they experience more pain as they get older, that they have more hospitalizations because of other aspects of their disease. Already they're showing delay in terms of their executive development from 3 years of age and earlier. So we should be screening and supporting these executive difficulties from very early on in development. More recently, for the first time, we looked at Irish children with sickle cell disease and looked at a group of children who were on transfusion in Crumlin. And we knew already from the research literature that children who are on transfusion, so regular blood transfusion treatment, are more likely to show more executive difficulties. But what we found was that children who were on transfusion the longest were showing more difficulties. And what we were really trying to establish in this study was whether we could use some sort of easy way of actually screening or just kind of quickly capturing a child's executive difficulties in a practical way in the clinic that doesn't involve loads of financial resources and loads of time, because they're the current barriers that exist. And we found that this kind of quick iPad-based measure, and when children were actually in clinic waiting for the transfusion treatment, was really effective at actually highlighting some of the executive deficits that we know exist in these children. So just moving briefly on now to some other more general research focused on executive functioning, because executive deficits are common across many diseases and many disorders, and children as well who come from poor socioeconomic backgrounds can present with a lot of executive difficulties in the early days of school. It's important that teacher understands what they are and knows how to support them from the get-go. So we looked into this over the last few years in the Irish context. And we know already from the existing research that's out there that executive development is impacted by the school environment in a number of different ways in terms of teaching styles, formal interventions, and so on. But what we didn't know was whether teacher understood their role in terms of the importance of executive development. So we conducted 2 studies. We conducted an online questionnaire and a couple of focus groups with Irish primary school teachers. And we wanted to establish both their understanding of executive functioning and their experience with it, and with the kind of assessment and common disorders that are around executive difficulties. So what we found, surprisingly, was that, nearly 65% of teachers said that they had not heard of or were unsure of the term executive functioning, because they hadn't actually come across it in their training, and a lot of them hadn't come across it in their practice. And a lot of them were unsure at how to pick up on some of these difficulties in children in the classroom. So they believed that they played a key role in the development of students' executive skills, but they were unsure in terms of, how to pick up on some of these difficulties in the classroom context. And when we asked them what they felt the barriers to, and the facilitators of understanding neuropsych reports for the children who did receive assessment in relation to their executive functioning and other domains, and we found that some barriers there existed as well, in terms of actually the translation into the classroom was impeded by some of the language, because it wasn't, readily accessible to teachers. So some of the issues that were reported in the focus group setting are highlighted here. So we've lack of training, poor communication, systemic issues, and not prioritising executive functioning enough. So teachers felt that they didn't receive enough training, that their understanding of executive functioning was more based on, years of experience that they've had. So the more children they've had the opportunity to encounter, and I suppose the amount of trial and error that they've been able to use over the years. Lack of information and poor communication. So not actually being able to understand a lot of the reports or resources that are out there. Systemic issues. So lack of funding, or lack of practical ideas and resources for them to implement more generally in the classroom. And just, the lack of priority on executive functioning in general. So it was interesting that, teachers really understood their role in the shaping of the development of executive functioning in these children, but that, they just reported lots of issues. So particularly systemic issues in terms of actually being able to understand and to support the development of education, of executive functioning in the educational context. And this just means that, we do need changes in educational policy and changes to teacher education. And, in order to bridge that gap between research policy and practice, we need new policies that really put an emphasis on collaboration, so involve parents in terms of working with teachers, and also involve resources for teachers that they can actually readily understand and integrate. So this is just an example of a measure that we've been working on more recently. And the idea is to try and develop assessments that teachers can use in a non-diagnostic way to help them break down everyday classroom activities so that they can actually support the child in the classroom context. So I don't want to take up too much more time, but thank you very much. And that's my piece.
Michelle, could I ask you a quick question?
Sure.
Is that okay? Is that okay, Suja, while I think of it? Michelle, would children with ASD have executive functioning difficulties as well?
Yes, yeah. So, you know, what we find generally is that, you know, if you have, say, for example, now I work more so with children from an ADHD perspective, but executive difficulties are common in many neurodevelopmental disorders. And the children who have more executive difficulties are the children who just have more difficulties, you know, integrating across the board. So they're the ones who are more likely to struggle in school, who are more likely to struggle socially, because they can't use these executive skills to kind of compensate for their difficulties in other areas.
And we will be having a lot of discussion later on. So I'm going to, is that okay? We'll move on. Okay, so may I introduce my colleague, Dr. Joyce Senior. Dr. Joyce Senior is Assistant Professor and Director of the Professional Doctorate in Educational Psychology at the UCD School of Education at the University College of Dublin. I'm going to share Joyce's profile within the chat function. So I'm going to, Joyce, can I hand over to you then? Is that okay?
Thank you, Suja. Thank you
very much, Joyce. Thank you.
Hello, everyone. I'm delighted to be part of this webinar. It's highlighting a really important area for children, their families, and their teachers. In terms of my background, as Suja said, I was a teacher for 15 years before training to be an education psychologist, and I'm now director of the Educational Psychology Professional Training Program at UCD. So it's through my professional experience and research that I have been privileged to work with and learn so much from people living with rare conditions. And over the years, I've been really struck by how dynamic and proactive and progressive in terms of knowledge, research, and collaboration the rare disease community, or family, as I view it, is across the globe. So you are the experts, okay? So in this short presentation, I'm going to share with you what I have learned from listening to your stories. So Michelle has given an excellent introduction and overview of executive functioning in the context of general classroom functioning, as well as executive functioning in sickle cell disease. So what I'm going to look at now are how some of these difficulties can present in terms of what we call a cognitive profile in relation to school and the impact that they may have on a student's educational attainment and progress. But before I start looking at specific areas of need, I'd like to talk briefly about the idea of having a shared language across all rare conditions and the rationale for this. So when I talk about a shared language, I mean a shared language between those living with rare diseases, their families, and professionals, and educators. So everyone involved in the lives of a person with a rare disease. Because too often I see the most important person, that is the person living with the condition, not included in meetings. For example, at many individual planning meetings that I go to in schools or even colleges, teachers or disability officers at university level look at me when I say, you know, where is the child, or why is the student not attending the meeting? And they respond with various reasons, such as, oh, he's too young, or it's not appropriate that they're involved as it is about them. Personally, I find that very patronizing. And I just think that everyone, even those with severe and profound disabilities or those who are non-verbal, can be facilitated to give their voice regarding their needs. My underlying philosophy in all my work is nothing about me without me. So what is the rationale for a shared language? And I think the agreed aim of a shared language should be to support the young person in the most inclusive environment, whether that is a mainstream or a special school or in a further vocational center or college. We need to advocate or negotiate with schools so that they fully understand how the various associated difficulties with rare diseases may impact on learning, as well as social and behavioral engagement and mental health. For example, how might visual memory difficulties translate at a practical level in the classroom on learning spellings or interpreting and remembering graphs? And I was quite shocked to see those results shared by Michelle, but not surprised, because it's what I find also when I work with schools. You know, in all meetings, there should be a focus on strengths and needs. We should be mindful of the language used. There should be no reference to weaknesses when discussing any rare disease or indeed any child. We all have weaknesses and needs, but with supports and accommodations, their impact can be reduced. So while on the next few slides, I'm going to outline some of the more common neurodevelopmental disorders or areas of need, such as dyslexia, I have strong views about labels, unless they're absolutely necessary. So I've seen the long-term psychological damage done to families and particularly children who have experienced multiple diagnoses, sometimes at far too young an age. Unfortunately, in Ireland, and I suspect in many countries, that is driven by the requirement of to have a diagnosis in order to access services and supports. Now, thankfully, there is now a move away from that within our education and health systems, and the focus is starting to shift from assessment and diagnosis to identifying what resources and services the child needs in order to support them with difficulties such as attention, literacy, memory, writing, or organizational skills. And when working with families and schools, I try to help them see that a diagnosis is like a sat-nav for aiding us to establish what supports are needed in order to get us to the finish line and the end goals. For example, I think if we could view dyslexia or specific reading difficulty as a teaching difficulty rather than a learning difficulty, it would be more helpful. As with the right teaching supports and accommodations, children and adults can be supported to read. So in relation to any condition, whether it's PKU, SCD, 22q, cystinosis, we need to encourage schools to view the label as an enabler rather than a medical label, so that the focus is on what interventions and resources might be needed to support that student's educational and well-being needs. Apart from potential associated medical needs, in my professional and research experience, there are common areas of need across all rare diseases. And in fact, most of them are not unique to students with rare diseases at all. What's rare about specific reading difficulties or dyslexia? What's rare about maths difficulties or dyscalculia? What's rare about coordination and organizational difficulties or dyspraxia? There's nothing rare about these co-occurring areas of need. But what is rare, as Anne Lawlor so rightly says, are services and systems which put the child rather than the symptoms at the center. So while I'm now going to outline some of the more common areas of difficulty, it is from the perspective of understanding what is contributing to it so that we know how the child can be best supported. So what are the key areas of difficulty which are seen in the classroom and which teachers, educators need to be aware of in terms of potential impact on attainment and meaningful, inclusive engagement in education? And Michelle has outlined these in detail already. And they actually, coincide with the areas that I find, which include attention, concentration, working memory, visual perception, motor planning, motor skills, and processing speed. But what do these terms actually mean? Okay, so let's just take one small but very important aspect of cognition and learning and unpack what does visual perceptual difficulties mean and how it translates into learning and everyday skills. So when you read the literature, you see terms such as visual deficits, visual learning difficulties, visual spatial difficulties. But what does it actually mean? So it refers to the brain's ability to make sense of what the eyes see. Now, this is not the same as visual acuity, which refers to how clearly a person sees, for example, 20/20 vision. A person can have 20/20 vision, but still have problems with visual perceptual difficulties and processing. So why is it important? But good visual perceptual skills are important for so many everyday skills, such as reading, writing, completing maths problems, spellings, reading maps, graphs, even getting dressed. And without the ability to complete these everyday tasks, a person's self-esteem and mental health can be greatly impacted, and their academic performance and attainment are also affected. So still looking at visual perception, this item is from a subtest called the Visual Spatial Index in the WISC-5, which is one of the most widely used IQ or cognitive tests. So the visual spatial index provides an estimation of a student's ability to attend to visual details. And this visual puzzles test requires you to view a completed puzzle and orally select 3 pieces that together would reconstruct this puzzle. So have a look at this and see if you can figure out the correct response. So which 3 pieces from these 6 go together to make this puzzle? So the pieces have to go next to each other and not on top of each other. Okay, so I'm not going to put anyone on the spot, but the answers are 2, 3, and 6. So that gives you just a small insight into what it means when you hear the phrase, oh, she's visual spatial deficits or visual perceptual difficulties or visual memory difficulties. Visual spatial skills are core skills for so many important subjects such as reading, maths, geography, science, and technology. And in everyday life, visual spatial skills are used in tasks including, reading maps, driving, following instructions. They are core for spellings and reading. As if you think about it, spellings and reading, you are decoding symbols. So if you have difficulty with perception, it would be like trying to decode the symbols, letters in the Chinese language if you weren't familiar with it. So, their visual perception and memory skills are core deficits in dyslexia. But in relation to many rare diseases, such as cystinosis, for example, the research is limited in terms of whether the visual difficulties are part of the condition, or is there a specific learning difficulty, i.e. dyslexia, also going on? So more research on this is definitely needed. Now, I'm not going to go through this slide in detail, as the text is small and you'd need both very good visual perception skills and 20/20 vision to read it. But you can look back at it when you get the slides, and it'll help you see how complex visual perceptual skills are. So this summarizes some of the building blocks which are necessary to develop visual perception. And as you can see from this list, it's quite complex and it's tied up with so many of the key skills required for learning. For example, visual attention, which is the ability to focus on important visual information and filter out unimportant background information. So, many people with ADHD, for example, would find difficult. Another area is visual memory, which is the ability to recall visual traits of an object. So this would be a key skill for remembering spellings, for example. So all of these are the building blocks, they're all key to learning, and they're significant contributing factors to many neurodevelopmental difficulties such as dyslexia, dyscalculia, and dyspraxia, which I'm going to briefly cover on the next 2 slides. So dyslexia, which is one we are all familiar with, is characterized by cognitive difficulties in phonological processing, working memory, speed of retrieval, or how fast we can actually retrieve information from long-term memory. It's a difficulty that impacts on reading, phonological processing, or the ability to break down and read unfamiliar words, spelling, comprehension, and writing. So the other condition then is dyscalculia, which is less recognized, and it's a specific and persistent difficulty in understanding numbers and mathematical concepts. And often I hear maths difficulties are just dismissed as, oh, they're just you're not that good at maths, when in fact there could be a specific difficulty going on as well. Dysgraphia, which is also less recognized, affects writing abilities, and it can manifest as difficulties with spelling, handwriting, and actually getting thoughts down on paper. Dyspraxia, or developmental coordination disorder, that affects fine or gross motor skills, coordination, motor planning, sequencing, memory, and an area which is often not recognized is in relation to social and emotional skills. So that gives us a kind of a very brief and short insight into some of the more common difficulties which can be experienced. And there's a need for more research in order to know if there are common patterns of executive function difficulties within and across rare diseases. So where to from here? Well, I think we need more longitudinal population-based studies on psychoeducational functioning, which have multiple informants, i.e. the person with the rare disease, their parents, their siblings, and their teachers. We need more long-term dynamic assessments, as the once-off standardized assessments can be affected by factors such as tiredness, anxiety, and attention. And I think there can be a lot of damage done to conducting tests like that, and that IQ level actually sticks with the person then for the rest of their life. You know, they can be viewed in a different way depending on the outcome of that once-off standardized assessment. I think measures of possible neuropsychological correlates of academic difficulty, for example, attention, visual spatial skills, working memory, processing skills, are also essential, as they are fundamental to everyday living skills and have a huge impact on mental health if they're not understood and supported. We also need to know more about teacher attitudes and experiences regarding the effectiveness of education-specific interventions for students with rare diseases. So, in conclusion, you know, parents and young people with rare conditions tell me time and time again that they can deal with the medical issues, but it is often the social, school issues and navigating the educational system that they find the most challenging and stressful. I don't know if that is the case for you, but I hope that these presentations will be helpful and will empower you to advocate for your child or yourself if you're an adult learner or a student, in terms of better understanding of the specific areas of need, and also empowering you to advocate for a more inclusive education. You know, while there's amazing work, you know, been done in relation to rare diseases, I wonder kind of that medical and the psychoeducational and psychosocial issues are yet compatible. And personally, I think our future goal and challenge is to merge them into one shared language. So, you know, let's view the label rare diseases as an enabler rather than a label, and develop a shared language, one that is accessible, jargon-free, and most importantly, includes the person living with rare diseases. So I close by wishing you and your families the very best and thanking you for giving me the opportunity to present today and for linking in to this presentation. And if you have any comments or queries, I'd love to hear from you either during the talk later or by email, which you can contact me, the email listed there. So thank you.
Anne, would you like to come in?
Myself, Suja?
Any comment to make before we move to Bernadette?
Oh, lots of comments.
I know, I knew that you want to make it.
Oh, lots of that actually, Joyce, that made me feel so emotional. It really did, because it's the classic trajectory of 22q, and I would say a lot of similar chromosomal conditions, you know, where the early years are so caught up with medical issues, and then we move into learning and behavior, and it all knock-on effect into mental health, and there's no joining of the dots. None whatsoever. Our whole focus in 22q Ireland is a care pathway that goes beyond the medical needs and crosses across educational and health and social care. It's so, oh my gosh, it really did make me feel emotional. And yeah, thank you for recognizing that. And I do hope that together as we move forward, we can do oh, Suja, this is such a key area, such a key area. Thanks, Joyce.
Thank you, Joyce. That was a fabulous presentation.
It was.
I like the terminology, the shared language. I think that is something we really need, because so many conditions, you know, I think it's around 8,000 conditions, and you know, it's so important to have the shared language.
Absolutely. Yeah. Together we can do so much more. Absolutely. Yeah.
Thank you, Joyce. So further, I'm going to invite the next speaker, Bernadette Gilroy. Bernadette is a good colleague, lecturer in MTU, which is the Munster Technological University. But here today, Bernadette is very much coming as a patient, a parent representative from PKU Ireland. The floor is yours, Bernadette. So thank you for joining us today.
Thank you very much for having me. I'm really excited, like Anne, about this topic. It's something that is very much has been highlighted by our community and the PKU community on an ongoing basis. And whilst there are individuals who have a positive learning experience, there are also those that don't. So I will present information around PKU, and that's the focus of my presentation. So just to let people know what PKU actually is, it's a rare metabolic disease that results in a person's inability to break down protein And if this protein in the form of phenylalanine builds up in the bloodstream, it can cross the blood-brain barrier and can cause serious neurological consequences. It's diagnosed through newborn screening, and the current treatment is a very complex protein-restricted dietary therapy for life. So this is the main form of treatment for PKU, and it's important to highlight too that there is actually no cure for PKU as it stands. And the reason I mention this and I bring up a visual of the brain is PKU is something that's usually associated with newborn screening. It's usually associated with babies and young children for that reason, but people forget that it's a lifelong condition. It's due to a dysfunctional liver that directly impacts brain health. So what does the research, or how does the research actually translate to the classroom, the research that is available on PKU and executive function? So executive function, processing speed, you know, all of these issues have been that have been discussed, have been highlighted as areas that affect the PKU community. But on the ground, does this information actually reach the teachers? So prevalence of symptoms and learning deficits with early treated PKU has been highlighted, and in this particular manual, it's an educator's guide to PKU that was developed by the Boston Children's Hospital in collaboration with families and educators and clinicians, and it's a source to support educators. But within it, it highlights that at one sample of 55 children at one metabolic centre, they identified a range of different issues that affect learning. And what was interesting also is that it highlighted that these children, whilst their IQ wasn't terribly low below the average IQ for the population, you know, it really highlights, I suppose, the fact that these individuals, you know, they need the supports in order to reach their full potential. So in this case, they actually, you know, they have potentially the capacity to recognize, you know, that they have these deficits, which could potentially affect their belief and their ability to learn. So how might learning deficits become apparent in the classroom? And this is again mentioned within the educator's guide. And I think it's really important after what's been mentioned, because, you know, primary school teachers might not actually understand executive function. And this resource actually highlights to them, you know, what it might translate as in the classroom, things that you might need to look out for, rather than stating, you know, using scientific language, scientific terms, if it's something that they haven't covered in their training or haven't covered for some time. So practically, what might it translate as? So these are some examples that are given in the educator's guide as well. So it mentions ADHD-like behavior, such as hyperactivity and inattention, difficulty with math and reading comprehension, trouble multitasking and following multi-step instructions, difficulty finishing tests or assignments in time allotted and keeping up with note-taking, difficulty understanding charts and diagrams, trouble comprehending orally presented materials, low energy and fatigue, struggling to pack a backpack or fasten a jacket, sitting alone at lunch or recess, and worrying to the point of becoming sick. So these were some of the different issues that were highlighted within that teachers may look out for. So I contacted parents, you know, around their experience of schools and what their communication with schools would be, and it's quite text heavy, so and it's small writing, so I'll read that out to you. But the first one is around every Monday morning in the case of taking a blood level. It's a fasting blood level. It's taken from the finger. So the tender finger on Monday morning following bloods, not too impactful. We may be running a little bit late despite an early start if the child is feeling anxious about doing bloods. And anxiety is associated with high phenylalanine levels. And I suppose it's really important to highlight, you know, as much as families and as much as adults with PKU adhere to dietary therapy, there are still issues, suboptimal outcomes being executive function being one of them, but also a dietary adherence is very difficult if you have executive function issues. So you're effectively blaming the victims. You know, you have problems with planning and organization, for instance. And also it has been high Phe levels have been associated with increased anxiety, which makes it difficult for doing blood work perhaps before they even reach school in the morning. So they may even present in school with high anxiety and have had a very difficult morning at the start of their week. So here's another comment that a parent would have sent their school. Her blood level result from Monday each week arrives back on Thursday. So subsequent levels may be elevated for 4 days without having made an appropriate adjustment to her diet. So in the case of PKU, if you do a fasting blood on a Monday morning, you may not get your result back until Thursday. It's already 4 days after the blood has been taken. So you're basing their now diet off of something that's already 4 days old. And lots can happen over that 4-day period. And it's important for educators to recognize that. When his blood levels are out of range, it can affect concentration at school. He may have headaches and his processing speed may be affected. So one instruction at a time really helps when this is the case. Here's another one: stomach upset due to drinks, new food combinations, change in eating routine. So this can also be apparent in PKU if they change formulas, for instance, if there's issues around the quality of the formula that they're taking. And gastral issues are not uncommon in PKU. Again, they can have issues around their experience in the classroom. So she has had an upset tummy today and yesterday, so she may have lower energy levels. So I've encouraged her to drink extra water in case she feels dehydrated. Again, there's planning around that. So the parent gives instruction to the child, but if they're feeling unwell, you know, their Phe levels might be already elevated. So again, their executive function may be affected. He takes 4 medical drinks throughout the day. 2 of these are at school. I tell him to take them on his breaks or whenever it is most convenient, depending on the timing with activities in school. He does manage to do this very well independently and is encouraged to do so, of course, as well. But I suppose it's important too, as I've mentioned, if a child is presenting with executive deficit issues, then that can affect their ability to plan and organize and to remember to take their drinks. And most schools, parents report that schools themselves don't see this as their role, and it's not their role as educators. But in the case of PKU, by not encouraging or keeping an eye that the child takes their drink is like taking their equipment away in the classroom in order to help them to be able to learn. So it's really important that the drinks are taken consistently throughout the day at different intervals to keep blood work balanced to avoid fluctuations during the day. This parent says we do not reward her for taking her drinks, as it's like brushing her teeth, just something she does every day for life to manage her health. And it's important too that, you know, educators recognize this and that they don't reward. It's something that happens in the classroom sometimes, and that isn't helpful for then managing it at home. So it's really important that they recognize this is just something somebody with PKU has to do to stay healthy. Her drinks are not very palatable, so she takes them refrigerated with a straw and also does this to protect her teeth. These are stored with an ice pack and straws in her lunch bag. And I've put spare medical drinks labelled in her bag in case of accidental spillage. And I'd be grateful if these could be stored in the staff room. She's at an age now whereby she may be a little bit more self-conscious about it. So again, PKU, you know, some of the research would suggest, you know, social anxiety, withdrawal, feeling different, you know, having a negative self-image, and, you know, having this condition. So children can be very self-conscious. It's important too to recognize that there's, you know, if a child does have an accidental spillage, that somebody is aware of the importance of them getting a replacement drink. You know, and that the child, again, organization and planning, they might need support around that at school to support their executive function. I'll drop in protein-free treats for you to keep in case of an in-class celebration day. This parent says, please let me know if there are any events happening that I may not be aware of. And many parents report that they actually join parents associations and they spend additional times at cake sales, pancake days, Halloween events, everything that happens around the school to ensure that their children actually adhere to dietary therapy in the school setting when there is a possibility that they may accidentally eat the wrong kinds of food, which does happen sometimes. So again, the other aspect that I wanted to highlight here is because it's a low protein diet, there needs to be a holistic approach to support executive function. So low protein doesn't necessarily mean high carbohydrate. So in some instances, you know, sugar can seep in as very high into a very high volume, you know, for children with PKU, when a lot of their medical foods are already high carbohydrate, high starch based, and their drinks as well are very often sweetened as well to make them more palatable. So it's really important that there is a healthy, holistic approach to eating in PKU to support their executive function. I asked a 10-year-old girl what it was like when her blood levels were elevated. So when her levels were high is the language that she would understand. And she said to me that it's like inside my brain is like a sunny day all the time. But when my levels are high or my levels are off, it feels like the clouds have come out in my head and I cannot see properly through the clouds and I cannot think straight, is what was said by this particular 10-year-old. And the next story I'm just going to share with you is an adult with PKU reflecting on his experience of education and childhood. And this was developed as part of a Living Lens project that's going to be released over the coming months. But this is a little snapshot, and Tom talks about his childhood and PKU.
There was that sense of isolation for PKU patients from an early age. I have a distinct memory where I was at a neighbour's house as, let's say, 5 or 6 year old child, and I was offered a jam sandwich with regular bread, and not knowing how to articulate my condition, I just took the sandwich and ate it, and I felt a lot of regret over it. I felt shame. My teenage rebellion was I was off my diet, and that had ramifications for my concentration levels. I performed poorly in my state examinations, and that was very much a case of my diet having a detrimental effect on my ability.
So again, I highlight to you that we are blaming the victims by not supporting them to adhere to dietary therapy, and we need to improve
There's that sense
dietary therapy to support these patients. So I've listed some recommendations here that we need to identify what supports children need, that they need early. So not to use a reactive approach by waiting for issues to arise and address them. So the information leaflet that we're currently given as parents to give to schools highlights that the school, the teacher, if they notice anything, that they contact the parent, and the parent then contacts, Temple Street. But I think it's really important that from very early on that the school actually recognises and is able to identify what supports are needed, and that perhaps then there could be some kind of ongoing support that is also required. We also need to be careful on the language we use around dietary therapy, because we tend to say things like, you're such a good girl, you're such a good boy from very early on for adhering to dietary therapy, and what happens when they don't? What happens when they forget? What happens when they don't plan and their organization is affected or their executive function is affected? They feel guilt, adults report feeling shame, and there's implications around this, from very early on, when they're getting this positive feedback and reinforcement from their parents, from their teachers and people that they look up to, from clinicians. We need to keep channels of communication open between all stakeholders, so educators, clinicians, and also, parents, families, and especially the person with the condition. So we need to create co-designed handbooks for educators to support children. And these need to be developed by the children themselves, the families, the clinicians, the dietitians, the metabolic nurses, and the educators. All stakeholders need to come together and to provide these supports. So I truly believe with person-centered supports that all children and adults with rare diseases can reach their full potential. And I think we have an absolute responsibility to make sure that this happens. Thank you for listening.
Thank you, Bernadette. I'm going to hold the thought and discussion because I'm conscious of the time. Will that be okay? I may move to the next speaker. Thank you so much for sharing your experience, Bernadette. So Cristina is our next speaker, Professor Dr. Cristina Romani. She's a reader in psychology and psychology department, College of Health and Life Sciences, Aston University, Birmingham, UK. So I'm going to hand over to Cristina. I'm going to share Cristina profile through chat. Thank you.
Okay, do you see my screen? You hear me fine?
Yeah, we can see your screen
Okay,
fine.
thank you very much. So thank you for this opportunity to share my thoughts. It's really welcomed. So today I'm going to talk about executive functions in comparisons with other skills in children and adults with PKU. So PKU have already been nicely introduced by Bernadette, and executive functions by Michelle. So I'll go straight into the topic of my presentation. So impairments in executive functions, together with impairments in speed of processing, are the most commonly reported impairments in early treated children and adults with PKU. And these difficulties, as we have heard, can definitely impact performance in the classroom in a variety of ways. And in fact, children with PKU have lower academic achievements than peers, they control children. And these difficulties get worse with age. Right. So in the talk, I'm going to cover a number of issues that relate to the nature of these difficulties. But the main points I want to bring home is how difficulties in PKU, cognitive difficulties in PKU are specific, are not generalized difficulties. And this is important to understand that, and this could be important for other rare diseases as well. So first of all, impairments in executive functions are reported consistently in children with PKU, and some studies show that these impairments are present even when controlling for other skills, other factors. And these deficits are severe. So to give you, I don't know if I can try to give you a sense of severity by saying that they range between half of a standard deviation to 1.5 of a standard deviation from the control mean. What does it mean? For half of a standard deviation, it means losing 19 places in a distribution of 100 scores from a mean of 50. So if the average of the population is 50, these children will have a performance that is 19 places below 50. Or, you know, if they are one standard deviation below the control, will mean losing 34 places. So severe impairments. And these impairments relate to metabolic control. So they are worse when dietary control is worse and or when diet is discontinued earlier. Finally, these impairments are still present in adulthood, so they don't go away. So first of all, I want to address the question whether these impairments are specific or reflect other factors, for example, task complexity. So executive functions are important for complex tasks. And so they're generally assessed with complex tasks. So one can then argue that the poor performance in this task just reflect task complexity in a system that is depleted of general resources. So they reflect general resource, the general decreasing resources rather than specific deficits in executive functions. So I'll give you an example of the tests that are used to test, to assess executive function by a neuropsychologist. This is called the symbol digit coding test, in which you have to associate symbols with digits, and you have to do it fast in a unit of time. And this is a good example because a task like this involves a variety of different skills. Involves flexibility, short-term memory, visual motor coordination, speed of processing. So a combination of impairments can create the difficulties that we see in this task, rather than a specific impairment in itself. And this question of specificity is linked to the question whether we can interpret impairments of executive functions simply as the consequence of a reduction of speed of processing in PKU. So we said speed is important in PKU. Speed is important to complete complex tasks, because any delayed delayed to carry out any of a number of iterations can accumulate, so that in the end the child or the person may not have enough time to complete a task, to reach a solution, or the person may lose track in the series of operations that need to be completed, because information is not available at the right time. In any case, is this the case that do executive functional impairment are executive function impairment only the consequences of being slow? Well, this does not seem to be the case. And this is because impairments are found also in tasks where speed is not a premium, and because these impairments accounts very well for impairments in visual attentional tasks, but less well for impairments in language tasks, or better say, for increased reaction times in language tasks. Because in this task, the problem seems to be more being slow at making a decision, rather than being slow at each and every processing operation involved in these language tasks. So in conclusion, my take is that PKU produces both general impairments in speed of processing, but also specific impairments in executive functions. So yes, impairments in executive functions, impairments in speed of processing, but I think it is important to realize that there are also impairments in other functions in PKU. For example, there are impairments in fine motor skills and impairments in visual spatial processing. So, for example, people with PKU may have some more difficulties than control participants in copying a complex figure like the one shown here, or remember that figure from memory. So the other point that I want to make is that these impairments are in the context of normal or relatively normal performance in other functions of tasks. So in PKU, there is generally good language, so good naming, good comprehension, good morphological and syntactic skills. And there is also good long-term memory and a good learning, and especially for verbal information. So for example, if asked to learn a list of words like the one shown here across a number of trials, children and adults with PKU do well. And yes, there are instead reports of memory difficulties with visual spatial information, but I may argue that these difficulties are more the results of problems in processing visual spatial information rather than problems in remembering this information. So problems in memory and learning do not seem prevalent in PKU. So let's leave that slide to move more quickly So my take from reading and studying the literature on PKU is that the cognitive profile, and studying people with PKU in my research, is the cognitive profile of PKU children is disease specific. So in this slide, I've compared the impairments that we see in PKU with those that we see in other developmental disorders. So we see this is the column for PKU, the column for dyslexia and dysgraphia, and in PKU there are no minor. Sorry, I think I okay, I missed the slide. Sorry, I don't know, but I'll say now. So in PKU there are no minor difficulties with reading and spelling, learning new words, and with phonological tasks that are associated with dyslexia and dysgraphia. So all tasks where there are clear problems in dyslexia and dysgraphia. And instead, there are, there are problems with visual short-term memory, visual learning, with executive functions, where children with at least the phonological variety of dyslexia and dysgraphia have no difficulties. So my take is that the minor problems that we can be seen in PKU in learning to read and write are more the consequence of difficulties of living with a chronic disorder and or coming from interactions with problems with executive functions rather than a primary problem with learning. And if we contrast PKU with ADHD, again we see a contrast. In neither disorders are problem with reading and spelling, but and in both disorders problem with executive functions, but the pattern that we see, the relative impacts of speed of processing and accuracy on performance is different in these two disorders. So speed of processing is impaired in PKU. In ADHD, there isn't really a kind of an overarching problem with speed of processing. There are some long reaction times because there are lapses of attention in ADHD, but the distribution, the average reaction times, the average speed of response is not impaired in ADHD. Far from it, some responses, in fact, are very fast because children with ADHD are impulsive, so fast responsive, but also a low accuracy, exactly the opposite of what we see in PKU. So in conclusion, I think, also concluding the webinar, I want to kind of bring back what Michelle has started to tell us, so how these cognitive impairments may impact working in the classroom. And so starting from the consequences that reduced executive functions may have on tasks performance, can understand how reduction in sustained attention can create difficulties in persevering on a task, maintaining focus on a task. Difficulty in planning may result in difficulties in properly allocating the right time to different task components. Problem with flexibility may result in difficulties in shifting focus and resources depending on changes in conditions and demands. Reduction in the ability to inhibit irrelevant stimuli can result in being more distractible. A reduction in working memory capacity can result in forgetting tasks and or the order in which different components of a task need to be carried out. But I wanted also to drive attention on the consequences of other impairments in children with PKU. So already talked about speed of processing, but fine motor skills may impact on handwriting, visuospatial skills on understanding and remembering diagrams and complex visual information, and on the ability to complete mathematical tasks. There is kind of, a suggestion there could be difficulties with contrast sensitivity, but also only in children with PKU that are late treated, or where there isn't a good dietary control, and this may impact reading. This is kind of, is more, this last point is more controversial. So in conclusion, what I've argued is that children with PKU suffer from a specific pattern of cognitive difficulties, which specifically involve executive functions, but is not limited to them, and while other skills are not affected. So I think to better help children with PKU, but also children with rare disorders in general, we need to take into consideration not only reduced abilities in executive functions, but also other cognitive impairments that can be associated and they may contribute to poor task performance. And finally, we need to consider, very important to consider skills which are intact and they can be exploited in a compensatory way. And the final point that also, is linked with what is being said by other speakers is the importance of linking performance in neuropsychological tasks that have been performed by clinicians, by professionals, with difficulties in everyday tasks and difficulties in the classroom. So we need to link behavioral results to observational and qualitative studies. We need to test executive functions with more ecological tasks, and there are a number that are available. And we need to test more skills, expand, the range of tasks and abilities that we consider. So for example, one suggestion is to test prospective memory, the ability to not only to remember past events, but to remember to do tasks in the future. That is also very important, for managing different tasks and be successful. So thank you, and I can, I would really welcome any comments, and you can send them now or later. Thank you very much.
Thank you, Cristina. Thank you so much for the wonderful talk. So I'm going to hand over to Professor Amy Jane McKnight. Professor Amy Jane McKnight is a rare disease research lead from Northern Ireland. She's a professor of molecular epidemiology and public health at the Queen's University Belfast. I'm going to hand over to Professor Amy Jane McKnight for moderation. Thank you. Cristina, would you mind stop sharing your slide?
Sorry.
Oh,
yes,
thank
absolutely.
you. Thank you. So we can see everybody's face. Thank you.
Yes.
So thank you very much, everyone. That was an excellent run through of some very different experiences and perspectives. And I'm very happy to open the floor to any questions and discussions. I guess some of the things that comes out to me is that, some features are common to all rare diseases, and it seems very much throughout what everyone has been saying, that there could be a more proactive approach taken, but sadly just the tools and the resources aren't available there yet. So I guess one of the things that came to mind was some of you were talking about perhaps a toolkit that would be helpful for children, for parents, and for healthcare providers. And if you had the choice and unlimited funds, what would be your top 3 priorities?
Can I answer that one, AJ?
I'd like you all to answer it. Go for it, Anne.
Okay, well, a top priority would be that all children with educational differences get their, here it's NEPS assessments, so they're psychological assessments to determine their individual needs. Unfortunately, that doesn't happen. So that would be, I'll leave it that at the top one, because I think unless and until that happens, we really don't have much of a chance. And neither do they, the kids, more importantly. Yeah.
Can I, oh, sorry. I was just going to mention, I totally agree with Anne. I think a needs assessment is really important, and it's something that the rare disease community are commonly asked, you know, what their educational needs are, you know, for each specific condition. And in many cases, we actually don't know, because an educational psychology assessment hasn't been carried out, or if it has, it's been too early. They haven't had, you know, ongoing assessment. And I suppose too, it's about educating parents and families to understand what executive function is, so that they can identify needs. And also for teachers, after what I've just heard today, you know, and educating teachers on executive function and what it is, and the implications, you know, in an education setting and outside of education as well, for individuals to reach their full potential. And like I mentioned as part of my presentation, the third point then would be definitely a resource manual that's co-designed, you know, with all stakeholders. I think that's really, really important going forward. Thank you.
Oh, AJ, I would just say, like, just Bernadette has reminded me there, we had to develop our own 22Q educational resource, and what started out as a very small one-page thing turned into an 8-page thing. It was that kind of, and even at that we have to try and whittle it down. So it's all about, you know, attention, memory, executive functioning, communication, social skills and behavior, sport, support, math, reading comprehension, motor and sensory, mental health, and school absences and fatigue. It's such a vast area. And I'm reminded yet again of the enormous burden on parents. Because as Joyce said earlier, you know, people see their own symptom. So a teacher will only see the teaching difficulties. A surgeon will only see the surgical. You know, the feeding, the speech and language will only see the speech and language. But there's so many issues, you know, attached to one condition. Absolutely. And the parent is left with the overall burden of all of that. So
Cristina, I'll come to you, and then Michelle, if that's okay. Cristina?
No, I wanted to say, yes, it seems to me as well that education is so important, is a key priority. But, you know, in light of my talk, I also kind of, you know, think that it's very important that researcher, parents, professionals together understand also the specificity of these different impairments. These impairments the common characteristics for different disorders, and also they vary from one person to the other. So it's important to stress not only what is bad, but in part also what is good, you know, so that there is also, you know, people are also given a sense of what can be done, what they can achieve, you know, the skills on which they can rely to compensate on the areas that are more problematic.
Thank you very much. And Michelle, did you have something to add?
Yeah, I suppose just to add just support for teachers in the classrooms, because I think often people are waiting for that assessment or waiting for that, you know, additional diagnosis, and it can take a couple of years. And I think, you know, there's often lots of small things that can be done that can make a really big difference. And just with, I suppose, some training and resources, there's a lot of practical things that can be done in the classroom that are not just helpful for children with rare diseases, but across the board, but specifically, you know, would really boost some of these children.
And do any of our attendees have questions for our expert panelists today? You can ask them just within the general conversation or type them into the chat function, if that would be helpful.
Can speak as well. So I let them, they're allowed to speak. So if anybody want to come in to unmute your mic and you can speak yourself.
And so I'm aware there's quite a few coaches online for executive dysfunction in children. Do you think have you any experience of them, and do you think they're any use or would be beneficial to have a trained service like that available to the children affected? I'm going to ask Anne for it again because she knows everybody and everything. Is that something you've come across, Anne?
No, it's not. And you know, and we did a couple of podcasts with Hibernia College there on 22Q AJ, and I asked about, you know, the level of EF knowledge and awareness amongst teachers. I really wasn't aware that it was that high, Michelle. That's kind of a bit scary. And I do agree with, you know, I'm a great believer in co-learning. And I think if parents, if there was some mechanism whereby parents and teachers and SNAs could learn together, you know, about these issues, it would maybe, it would help relationships also to do things like that, I think, because sometimes the parents are, if they don't have the knowledge themselves, you know, how can they approach the teachers and say, you know, my child is having difficulties in this area, I don't know what they are, could you help? And that kind of thing. I think it would be very useful, because as Michelle said there, you know, it can take years for an assessment, and, you know, maybe we shouldn't be relying too much on those types of things. Yeah.
Sorry, AJ, myself and Joyce is involved with the national training program. And our plan is to train up to 3,000 SNAs. At the moment, we trained up to 500. Another 1,000 is going to start the primary and a complex care module in January. So I know it's only 12-hour section, but we could highlight or a signpost there, at least 1,000 will get some kind of understanding about the executive functioning for a children with a complex condition in the school settings. So I don't know, Joyce, I know you train teachers as well. Do you want to come in and say anything there?
Yeah, absolutely. I mean, I think in terms of assessment, we are never going to be able to assess all the children. And, you know, I would have this discussion with schools when they, you know, going to try and prioritize students. Many of the students, you know, they share the same difficulties. And if we could come at it a different way in terms of what is good teaching, what's good pedagogy, but what will benefit one child also benefits another. I think that's the way. We're never going, and there is, as I said in my talk, a move away from assessment, and particularly in NEPs, it's much more a consultative model now. So the individual assessments are being reduced. So I think, you know, linked to that, I think it highlights the importance of us as a group working together, maybe through research to collectively establish what are the common areas of need. And then, like through books like that you have, and that this is fed back to schools and saying, well, okay, we don't need an individual assessment. These are the areas of need. Let's put those into their student support file or their individual education plan, you know, and that takes the focus away from the title, you know, rare disease, or I do hear some, you know, teachers would say to me, oh, well, you know, we don't want to push too far, or, you know, they have a medical condition, and there can be lower expectations then as well. So we have to be mindful of that as well. But I think absolutely working with teachers, working with SNAs, they're key. Because without SNAs, a lot of children would not be in school. They just could not cope. So I think definitely, Suja, if we work to include more inputs on executive functioning, and you know, maybe an input on rare diseases to highlight that within the SNA training. Absolutely. But I think, as I said, collectively we can do a lot, which will be much more effective than going in and trying to assess every child, because it's just not going to be possible for NEPs or for parents, because the costs are so high.
Thank you very much, Joyce. I'm very, very conscious of time. So very briefly, Cristina, and then I'll pass over to Philo to do the wrap
No,
up.
I think, I absolutely understand what Joyce is saying, and I agree that some general advice would be useful, but also you have to be mindful of the individual differences in these children. So the advice for a child that is ADHD and is impulsive, it tends, to respond quickly and get it wrong. Is very different from a child with PKU, which are usually quite careful and take their time, they're not uncertain about their answer. So they need the opposite, need to say, well, yeah, do it. Don't worry so much, don't be so anxious about your performance. So, it's trying to find the right balance, isn't it, between some general advice and some individual advice. So is that kind of,
Perhaps moving into the elements of an individual passport that has generic components, specific to the individual child. Thank you very much. I very much appreciated hearing from everyone, and I'll pass over to Professor Thilo Kroll to wrap up and close out the session.
Yeah, thank you very much. It's been a fascinating afternoon. I think we had sort of a really exciting whistle-stop tour, heard a lot of perspectives but also challenges around determining executive functioning, and also providing adequate supports from all the speakers. What stood out to me is sort of the difficulties of separating out the different elements of the brain development over time, assessing it with the adequate measures at the right time in the right space. I think Cristina mentioned ecological measures are missing. I think it was Joyce, you pointed out that actually longitudinal measures, are missing, and to look really across time. We really saw, I think, in all the presentation, it is not only an issue of the child living with the rare disease, or the families living with the rare disease. It's a systemic issue that the supports need to be put in place at an early time. They needs to be a longitudinal, person-centered approach. And what stood out for me was sort of also how we use language, how we work in inclusive ways. It's not just, it's the language is a great start, and it's a really important element, but also how we actually work in an inclusive way to address the needs of the child at any given point, and obviously also adults, because it doesn't, it takes, as Michelle pointed out, 20 years, for the brain to mature. So I was thinking, I was reminded of some of the things that Joyce highlighted. I read a few years ago a government document, a Norwegian government document, that spoke in 1969 of reverse engineering, and it meant to shift the focus away just from the problems, of a child to the environment, and saying, do we create a more inclusive, supportive, needs-driven environment that we actually need to put in place with the right resources? So shifting away the discourse from just detecting problems, and Cristina highlighted that as well in terms of compensatory skills, and looking at telling the whole picture, giving the full picture. And then one final maybe comment or two is, obviously what came out is also the differential vulnerability, but also differential skills that children have in the context of their individual lives and circumstances. The diagnosis is one thing, but then all these things that happen around it, the layeredness, the social dimensions, the ecological dimensions around it. And then maybe one final thing is looking at perhaps beyond sort of some of the rare diseases to other models of support, in terms of pediatric cancer supports, for instance, that have been in existence for many, many years, in a way you actually work in a systemic way, in some cases with the entire school, and you also bring also the students, the pupils into the discussion, so that social isolation, those kind of things, can be preempted potentially. But so thank you very much. It's been an exciting afternoons. I would like to thank also Dr. Suja Somanadhan for bringing everyone together, you know, and I would like to thank every speaker. And it was also a really good story that we heard actually unfolding there. You know, I think the sequence of the talks was excellent, and also very much through Anne's and Bernadette's very, you know, life experiences and bringing that life into the afternoon as well, and you know, highlighting quotes and experiences, and also all the comments that are there in the chat box. So so without further ado, I'd like to close officially this meeting. We're already a bit over time. There will be recording, as I understand, and that will be made available and hopefully watched by many more people. Okay, thank you very much.